Let's review some clinical applications of precision medicine, starting with the field where it has seen the greatest developments and the most visible success, oncology. Oncology is the stage where molecular big data are transformed daily into targeted therapeutic choices, a substantial change that is literally redefining cancer treatment. Let's think, for example, of the case of Angelina Jolie, where the identification of specific mutations, such as those in the BRCA1 and BRCA2 genes, and her family medical history, made it possible to estimate her risk, leading to proactive and personalized measures like a preventive bilateral mastectomy instead of the standard therapeutic approach. The genome is like a static blueprint of the cellular building. To fully understand cancer and its complexity, we need to analyze many other levels. A very important level is the transcriptome, the RNA, which is the collection of all gene expression products at a given moment. RNA is the dynamic map of cellular activity that tells us which genes are turned on and which are off, and how intensely the genetic instructions are working. Techniques like RNA-seq provide this functional snapshot, integrating it with static genomic information. We can further enrich the picture with the expression levels of microRNAs, small non-coding RNAs with regulatory functions, or with metabolomics or proteomics data, meaning the omics holistic study of proteins. The ultimate goal is to recreate the entire network of interactions and identify biomarkers that represent the functional and aggressiveness signature of the tumor. Today in oncology, we no longer limit ourselves to administering standard treatments like chemotherapy, but instead aim to stratify patients by understanding the molecular profile of the tumor. To stratify, the tumor genotype is often obtained through gene panel sequencing or targeted genetic tests, which allow us to apply targeted therapies. By targeted therapies, we mean drugs designed to act on specific molecular targets. Let's look together at two classic examples of success. The first is the treatment of patients with breast cancer. The use of the drug trastuzumab is aimed at patients who have high levels of HER2 receptor expression. This is a receptor that promotes uncontrolled cell growth. In the 1980s, with advances in molecular biology, they discovered that about 20% of breast cancers had an excessive amount of the receptor HER2, also known as ERBB2. This alteration is linked to a worse prognosis. This led to the creation of specific antibodies against the HER2 receptor, and in 1998, trastuzumab was recognized as the first monoclonal antibody capable of blocking a protein that causes cancer. This drug revolutionized the treatment of HER2-positive breast cancer, becoming a life-saving standard therapy for millions of women around the world. A second emblematic case concerns the treatment of chronic myeloid leukemia, CML. In 1960, the Philadelphia chromosome was identified in Philadelphia, marking the first genetic abnormality specifically linked to a neoplasm. This abnormality results from a chromosomal translocation that produces the BCR-ABL protein, an oncoprotein that causes excessive production of white blood cells. The identification of the BCR-ABL protein as a clear genetic target led researchers to develop a specific inhibitor, Gleevec, effective both in vitro and in vivo. The compound stood out from other anti-cancer drugs because it showed no effects on normal cells. His first clinical trials were a success, and in 1999, the Food and Drug Administration recognized it as a life-saving drug, a registration process that was significantly faster than average. So we understand that the molecular profile of the tumor is not just diagnostic information, but also the criterion for selecting the most effective drug. If we pay attention to the timeline of these two discoveries, we see that decades passed from discovery to application. Helped by increasingly user-friendly technology and with the goal of systematically characterizing as many tumors as possible, the program The Cancer Genome Atlas, or TCGA, was created. The Cancer Genome Atlas is the emblematic example of how the big data approach has transformed cancer research today. The Cancer Genome Atlas is a catalog of genomic alterations that examines over 11,000 patients and more than 30 different types of cancer. This project has systematically characterized molecular alterations. Using various omics techniques, such as RNA sequencing, whole exome or whole genome sequencing, DNA methylation, and microRNA sequencing. To these characterizations, protein expression levels and clinical annotations were added, creating a true multi-omic atlas of global significance. Researchers use this data to compare tumor samples with normal tissues and identify specific molecular signatures, leading to a new classification of the disease based on molecular etiology rather than just histology, meaning the analysis of tissue type. Let's go back for a moment to microRNAs, or mRNAs, small non-coding RNA molecules just 20 to 24 nucleotides in length. They have a crucial function. They regulate gene expression by binding to messenger RNAs to inhibit protein translation or promote the degradation of the RNA itself. In recent years, mRNAs have been recognized as key regulators in cancer biology. When deregulated, they influence tumor development and progression, as well as patients' responses to therapies. In the context of oncology, mRNAs can act in two ways. As oncogenes, promoting tumor growth. For example, MIR21 is often overexpressed in many types of cancer, contributing to aggressiveness and resistance to chemotherapy. MRINs can act as tumor suppressors, serving as a brake and inhibiting the proliferation of cancer cells, or even inducing programmed cell death, also known as apoptosis. A classic example is the miR-15 A16-1 cluster, which is frequently deleted, meaning removed, in the tumor cells of chronic lymphocytic leukemia, or CLL, thus removing a crucial control mechanism. mRNAs are widely studied because they are active molecules and offer us two major opportunities: discovering diagnostic biomarkers or serving as therapeutic targets. As biomarkers, we take advantage of the fact that mRNAs display specific and distinct expression profiles in malignant tissues, known as mRNA signatures. They are exceptionally stable in bodily fluids, such as blood. This makes them minimally invasive biomarkers for early diagnosis and prognosis. For example, think of MR21, a biomarker for lung cancer, and MR155, a biomarker for breast cancer. On a therapeutic level, the goal is to modulate their expression to correct the dysregulation. This way, we can restore the function of RMIs that act as tumor suppressors using RMI mimics, or inhibit the activity of RMIs that act as oncogenes using antagomers. Liquid biopsy is a non-invasive diagnostic tool that analyzes circulating tumor DNA. Also known as ctDNA, it is released by tumor cells into the bloodstream. While traditional biopsy provides a static snapshot of the tumor at a single moment and in a single location, liquid biopsy offers a dynamic, real-time snapshot of the disease's evolution, like a continuous video. Liquid biopsy allows for less invasive diagnoses, using, for example, a blood sample to search for genetic mutations. It facilitates monitoring the progression of the disease by measuring cord DNA levels over time. In this way, screening people at risk also becomes easier. Furthermore, it can detect drug resistance mutations in real time. Let's consider a concrete clinical example in non-small cell lung cancer, NSCLC. Many patients with this type of carcinoma have activating mutations of the EGFR gene, and they are treated with tyrosine kinase inhibitor drugs, EGFR TKIs. However, many patients develop multifocal disease progression after first-line therapy with EGFR TKIs, often due to the emergence of a new mutation, T790M. At this point, it's essential to identify the mechanisms of resistance. The patient may undergo a liquid biopsy to look for the T790M mutation directly in peripheral blood. The T790M mutation is the most frequently developed resistance mechanism during therapy with EGFR inhibitor drugs. We're talking about 55 to 60% of cases, and if its presence is detected in the blood, the patient would immediately move on to the second line of treatment. So, the liquid biopsy allows for monitoring circulating DNA in the blood and detecting an increase in the mutation T790M even before clinical symptoms or radiology show disease progression. This has the potential to redefine the field of cancer diagnostics, offering new hope to patients who, in the case of lung cancer, go from an average life expectancy of 12 months to that of 4 years.